I want to tell you about a patient I'll call Mrs. Alvarez. She wasn't a real single person. She's a composite of dozens of patients I've counseled over the years, but her story captures almost everything I wish more people understood about blood pressure in older adults. She was 78, active, sharp, still gardening most mornings. Her systolic pressure, the top number, sat around 148. Her cardiologist wanted her under 130. Her primary care doctor, who'd known her for 20 years, said 140 is fine for someone her age. And Mrs. Alvarez looked at me, the pharmacist reviewing her medications, and asked the question I hear constantly. Who's right? Here's the uncomfortable truth. They both were, technically. And by the end of this case, you'll understand why and what we actually decided to do. Blood pressure is written as two numbers. Systolic is the pressure when the heart contracts. Diastolic is the pressure while it rests between beats. The disagreement Mrs. Alvarez ran into isn't a case of one doctor being wrong. Major medical bodies genuinely set different targets. American cardiology guidelines push for under 130 in most adults over 65, and the newest update encourages under 120 for higher risk patients. Family medicine guidelines have historically been comfortable with under 140. European guidelines allow up to 139 for ages 65 to 79 and up to 150 for those 80 and older. As the pharmacist sitting across the counter from her, my job wasn't to pick a side. It was to figure out which target actually fit Mrs. Alvarez's body, not the average patient in a guideline committee's model. So I went back to the data, the same way I do for any patient like her. The pivotal trial here is SPRINT, the Systolic Blood Pressure Intervention Trial. Over 9,300 adults 50 and older, all at elevated cardiovascular risk, none of them diabetic. Half aimed for systolic under 120, half under 140. The trial was stopped early because the intensive group was doing so much better. A 25% drop in heart attacks, strokes, and heart failure, and a 27% drop in death from any cause. What made me sit up specifically for someone like Mrs. Alvarez was a sub-study on adults 75 and older. The benefit wasn't smaller in that group, it was bigger. A 34% reduction in cardiovascular events, a 33% reduction in death. The number needed to treat was strikingly low. Treat 27 older adults intensively for about 3 years to prevent one major event. Then a separate trial out of China called STEP tested a similar approach in over 8,500 adults aged 60 to 80. And unlike SPRINT, it included people with diabetes. Same story, a 26% drop in cardiovascular events with a lower target. So far, this reads like an easy case for pushing Mrs. Alvarez toward 120, but that's exactly where a lot of well-meaning prescribers stop reading, and it's where I don't. Here's what a purely lower is better reading misses, and it's the part I spend the most time on as a pharmacist, because I'm the one who sees the side effects show up. In SPRINT, the intensive group had more fainting spells, more episodes of genuinely low blood pressure, more acute kidney injury, and more electrolyte problems. A later pooled analysis combining SPRINT, STEP, and a third trial called ACCORD found that in adults over 60, intensive treatment raised the risk of low blood pressure episodes by 46% and fainting by 43%. In that pooled group, the reduction in overall mortality actually stopped being statistically significant. And SPRINT quietly excluded a lot of people who look exactly like patients I counsel every week. Anyone with diabetes, a prior stroke, a nursing home resident, anyone whose blood pressure was already low while standing. So when I looked at Mrs. Alvarez's chart, the first thing I checked wasn't her systolic number. It was her diastolic, the bottom one, and the one almost nobody asks about. Her diastolic was 62, trending toward 58 on her home readings. This mattered more than most people realize. A large analysis in the New England Journal of Medicine covering more than 36 million blood pressure readings, found that diastolic pressure independently predicts cardiovascular events. It's not just noise sitting under the systolic number. And there's a physiological reason. The heart muscle actually gets most of its own blood supply during diastole, the relaxation phase. Push that number too low and you can starve the heart muscle itself, especially if there's any narrowing in the coronary arteries. One cohort study found that a diastolic below 60 was linked to measurable heart muscle injury, detected through a sensitive blood marker. and a 50% higher rate of coronary disease events over 21 years. Another study in patients with known coronary disease found a J-shaped curve with chest pain. Both very high and very low pressure made things worse, with a sweet spot sitting around 70 to 80. Ms. Alvarez had mild coronary artery disease from a stent placed 8 years earlier. Her diastolic was already flirting with the danger zone before we'd even touched her systolic target. This is the moment where get her to 120 stops being obviously correct. So instead of chasing one number, we built her plan around 3 questions I ask for every older patient. First, is she healthy enough to plausibly benefit the way the SPRINT population did? Yes, independent, cognitively sharp, walking daily. That matters because in SPRINT, the people who benefited least and may have been harmed were those with weaker baseline cognitive scores. Second, what's happening to her diastolic number while we adjust her systolic number? We didn't add a new blood pressure medication. Instead, we adjusted the timing and dose of what she already had, aiming for systolic in the 128 to 132 range while protecting her diastolic above 65. Third, how do we actually measure this? Not in the clinic. Office readings can swing wildly. Sometimes falsely high from nerves, sometimes falsely reassuring. We set her up with validated home cuff, seated, 5 minutes of quiet, 2 readings a minute apart, averaged, morning and evening for 1 week. A home reading around 130 over 80 roughly maps to an office reading of 140 over 90, which is a translation error I see trip up patients constantly. 6 weeks later, her home average was 129 over 68. Systolic, sitting comfortably in range. Diastolic, low but stable. No dizziness, no near falls, kidney function unchanged on labs. Was 120 systolic achievable? Probably. Was it worth the diastolic risk in a woman with existing coronary disease? In her case, no. The marginal benefit didn't clear the bar against a real measurable risk to her heart muscle. That's really the whole lesson of this case. An individualized analysis of SPRINT participants 65 and older found that when you weigh the benefits, fewer deaths, less heart disease, less cognitive decline, against the harms, kidney injury, fainting, the overwhelming majority of older adults still came out ahead with intensive treatment. And interestingly, the frailest patients often had the most to gain because their baseline risk was highest. But most patients isn't the same as every organ system in this specific patient. And that gap is exactly where a pharmacist earns their keep. So if you're managing your own blood pressure or a parent's, here's what I'd pull from Mrs. Alvarez's case. Don't just chase the top number. Check the bottom one, especially if there's any history of heart disease. Below 60 diastolic is worth a conversation, not automatic alarm, but a conversation. Measure at home correctly before trusting any single office reading. And know that the right target genuinely shifts based on your overall health, not just your age. An active, sharp 78-year-old and a frail 78-year-old with memory problems may reasonably land on very different numbers, and both can be the correct answer for that person. The guidelines give you a starting range. Getting to the right number for your actual body is the part that takes a real conversation with whoever manages your medications.